Brian, I think we would be remiss not to bring the viewer back to the thoracic spine for a true mobilization with movement. We've covered reverse SNAGs, we've looked at the shoulder, AC joint. You and Brian Folk have just gone over spinal mobilization with arm movement that can be used in the cervical spine. If we drop down and we think about people with simple thoracic rotation restrictions, let's say, probably there isn't a finer mobilization with movement technique for treating those restrictions, and that is a SNAG. And if you wanted to elucidate on the difference between a SNAG and, say, a reverse SNAG that we've already talked about.
Well, a SNAG now becomes, or a SNAG is a mobilization with movement, whereas a reverse SNAG was a mobilization. So we're getting back to the very beginning. Right. We are going to now reposition bones in the thoracic spine and at the same time undertake a movement without pain.
Okay. So with a SNAG, what we're going to do is we're going to sustain our natural apophyseal glide. Again, the key points about performing a SNAG in the thoracic spine is to identify your spinous process, slip down below it in order to take the soft tissue slack up, utilizing your hypothenar eminence underneath the spinous process. If you're going to apply a central SNAG, drop your elbow down at a quite steep angle, not quite the vertical. Should you have to use the costrovertebral junction or your transverse junction, very important that you capture the rib as well. Getting your hypothenar eminence in your hand, again, angled more out of the horizontal, but slightly angular in order to follow that angulation of the rib. So again, coming over more unilateral in order to get that glide here for a unilateral SNAG or central on the spinous process. You will find that your position is always better if you stand on the side that you're going to rotate to. So what we're going to do is we're going to break, we're going to get a model in here, and Brian Mulligan is going to demonstrate.
Can I make a comment while we've got it here? When you're locating on this transverse process, I believe you're also influencing the articulation of the rib with the spine. And I think this might be why these procedures are successful. My background was in manipulation. I used to manipulate all joints. If you had a thoracic problem, I manipulated it. And I would find that I'd manipulate sometimes, I get a result, and sometimes I didn't. Once I started using SNAGs, I started to get a result virtually in every patient. And what was different with manipulating a spinal segment with a SNAG was also the involvement, I believe, of the ribs. And I think that's why they're successful.
Certainly.
And just another point, while we've got the spine, that's the only reason why I mention this, when the victim is sitting in this position and you locate on a transverse process, always have your hand sloping because that's the direction in which the ribs go. And you've got a lot of hand there. So not only am I on this process, this transverse process, but I'm on some of the rib as well. And the assumption here, of course, is that this joint, if it's the facet joint only, is jammed down, and you've got to release it as they move.
Fair to say that's your positional fault that you have talked about for many years.
That's right. Now, the other thing, of course, you've got a scapula, and they're a jolly nuisance because when you're standing up straight and you've got a good posture, it's hard to get in here. But if the patient puts their hands behind their neck, this is rigid, the scapula moves around, and you've got you've got a ready access to this area in here. You can get, this is out of the way then, and therefore you can locate where you want to locate.
Brilliant.
Yes, I'm just looking at those facet angles. They're pretty steep. You say 60? I would think it's...
yeah, certainly, you know, I think if you look at 60 degrees,
and you think of a kyphosis,
it's
60.
Definitely the elbow is going to be placed down in a more vertical position than what it might be in the cervical spine. So.
Yep, that's right.
Yeah, I certainly wouldn't argue that point with him. Brian, would you take us through the SNAG once again? Like the high points we want to make sure the viewer understands is central SNAGs, unilateral SNAGs, and maybe if you'll also talk about the indications. What drives you to doing, say, a unilateral SNAG more than that? Or might there be a time when you're thinking more of a rib, and what would be some clinical indications for that?
I certainly will. All right. I have a patient comes in, and they've got pain with which is spreading across the back, and it's thoracic. If they've got it, and it seems to be bilateral,
right,
and they might have pain in one direction more than the other, but they do have pain in both directions, I might initially try a central snag.
And it could be for just a motion restriction.
Yes.
If they're stiff, and
Yes.
that's all you're going to do. Pain's
Yes.
not a big part of the picture, so you could do it too.
But being honest, I would normally, because I'm always in a hurry when I'm treating patients, so I don't have the time, if they've got right-sided pain with right rotation, I treat them unilaterally on the right side. But never rule out this. I have treated patients on the left side, believe it or not, to restore right rotation.
Sure.
So you don't have a hard and fast rule. You do what works, you do what gives you an instant result, and you do what causes no pain.
Right.
So let's assume initially that he might have some pain with flexion. We're not dealing with flexion, but if he's got pain with flexion and it's fairly central, we would certainly use a central technique.
Right.
So can you just put your hands behind your neck? Now, when I'm treating a thoracic spine, look where his scapula are. Out of the way, right out of the way.
Right.
So that if I'm treating a thoracic spine, I've got access to ribs, much better access to the ribs as well as the spine itself. In that position, I will use my arm as a fulcrum because he's going to flexion. If it's a T8, 9, I will lift 8 up on 9.
Sure.
If I get on the wrong segment, the moment the movement starts, the patient will say, that hurts.
So that's part of your assessment.
That's part of my assessment. And it also tells me that I'm making what I believe is jammed further. I'm not releasing it. So I locate, as you said, using my hypothenar eminence, and to get the lift, he's a big guy, I use my legs. And I'm straddling the bed. I'm not going to just lift him like that. I can't. No one can. But by just straddling my legs, bending my knees, as I stand up, can you feel that? Now, I ask him to bend. Now, this is a very heavy treatment and it's very rarely indicated, but it's showing my positioning centrally on the thoracic spine. But now, he's a real patient, let's assume. Leave your hands there. Good. Sit up straight. Yeah. He has pain rotating to the right.
Little problem with his golf swings, for
yes,
example.
That's right. That's probably why he plays such dreadful golf. Now, I'm going to locate on the transverse process. But if you looked at that spine that you were showing, it's pretty hard to get. You've got the spinous process sticking out and the transverse process, it's hard to get into there.
Right.
So I get in as far as I can, and in doing that, I'm also lodging on the rib. I can't avoid lodging on the rib.
Right.
So there's a rib component to this the moment you use this technique. My hand is wrapped round, as you said, above the level.
With your
Yes, because the rib comes down. It's not till it gets round to the front, to the cartilage here or to the sternum, does it level out.
Horizontal. Right.
So there we are. Now, here we are. I've got the lift. And he will turn slowly because I must go with him. And round he goes, and there's the lift, and we'll stop there for a minute. When he goes as far as he can, I give over pressure.
Right.
And that's quite easy because I just rotate my trunk. I'm not just using my muscles of my arm. I'm just using my trunk, and there's the overpressure and back. And don't let the pressure off till you come back to the starting.
So some patients love this because you take them and you make them instantly pain-free. Eventually, do you want them to actively move when they can with this?
Yes.
Of course.
Of course.
Right.
Once it's better, okay.
Right.
But you give them advice. If it was a golf swing that did cause his pain, don't play golf for a few days. Let the thing settle down and get back to normal.
What about, in the States here and in some countries, certainly there are going to be the female patient that might be a little bit apprehensive about you putting your arm in front, and if we use the idea of utilizing a pillow in the front, I feel like if that's something you need
Well, you can use a pillow, but if you've got someone like Dolly Parton, you're not going to get your arms around.
That's right.
So you've got to use discretion.
Right.
So fold up a towel or a pillow, just so they feel a bit more comfortable with the technique. In New Zealand, we wouldn't worry.
Right.
But some people are always conscious of their body, and you start wrapping your arms around them.
We expect professionals that are going to explain what they're doing, and that there's a rationale for doing it, and you may address your patient and say, I need to do this, are you comfortable with it? And that is just our expectation about you as a professional, and we feel like it's probably not even necessary to say that, but
Oh, no, I agree. I don't treat any patient without explaining exactly, precisely what I'm going to do. And I'll say that involves wrapping my arms around your chest so that I can get some purchase and lift you.
Right.
And the patient, normally, in New Zealand, that's fine.
Could we address the person that you're working in, let's say, in this position, right rotation? You've done a lot of right rotation. Do you think it's important to maybe quickly check and see if they've lost any left rotation, as we've all experienced sometimes in clinic?
Thank you. Sometimes you go through this whole procedure, the overpressure might disturb another segment, and they might turn to the left and say, hey, that's sore further up.
Those are easy to clear up.
There you go, straight round, you correct it instantly. So I rush round here, so, oh, sorry about that, hands behind your neck, and you quickly, is that better? Yes. You do some fine tuning. You can see how that can happen. Just that extra pulling round, there's a little weakness there.
And even back to that small therapist that's treating a large patient, sometimes coming in and having an aide or someone else come in to help with the overpressure.
Oh, gosh.
But I think your point about getting the person at the end of the treatment table and you straddling the corner of it is so critical for us all protecting our backs.
I'm not just getting here and just lifting him. I couldn't do it.
No.
That would ruin my back.
No.
But I keep a straight back.
Right.
And I do some rotation with a straight back, and that makes it work.
Right. This concludes our unit on the thoracic spine, shoulder, in terms of MWM and the Mulligan concept. We want to take this opportunity to thank the viewer for your interest in this concept. We certainly hope that with Brian Mulligan's assistance and Brian Folk's assistance, that we've stirred your interest in the Mulligan concept. It's important that you realize that although you can go into the clinic now and you can think about these techniques, you may have the principles, it doesn't replace some of the valuable additional educational tools, those being attending a course where individual teachers certified by Brian Mulligan himself are able to help you with your handling skills. That is paramount in this concept.
You do need a hands-on.
Yes, you absolutely do. No matter how good you are, I mean, the assistance of having a teacher help you with your techniques. Brian?
There are 4 courses that the Mulligan Concept Teachers Association offers. It's an introductory course, there's an upper quarter course, a lower quarter course, and a follow-up advanced course. For those who have gone through that series of courses, we do offer a certified Mulligan practitioner program and an examination process to check your manual therapy skills to see if you have an adequate baseline level of skill that we can put you on the website and use you as a referral base for those who are looking for someone with this skill set. So that is available for those who are excited about this approach and want to take it to the next level. We'd like to leave our closing remarks with our main mentor and the brains behind the organization, Brian Mulligan, without which we all wouldn't be here. So, Brian, some closing remarks.
Of course. It's been fun with you guys, not only preparing this presentation, but through the years, being with you on course after course after course, and that's great. And you talk about the Certified Mulligan Practitioner exam. I'm getting emails now from all around the world, and people are asking, where can I go to see a Certified Mulligan Practitioner? Because they've heard how much we have to offer. And that's exciting for me. And as a result of these MWMs and NAGs and SNAGs, I've had just a fantastic life. I hope you have the same.
Thank you. And finally, thank you for our producers, Northeast Seminars, and
Short Fuse
Production, and our camera people today. We really do appreciate your effort on this educational endeavor. Good luck to you all.
Good night.
Good night.
Good night.